Yesterday I mentioned that we have sponsors for the Colloquium, very generous sponsors who have dedicated their resources to this event. I would like to take this opportunity to recognize them again and thank them. The DentaQuest Partnership for Oral Health Advancement, Delta Dental, Henry Schein, and APHA Press. And I'm going to ask representatives from those organizations to please stand so that we can recognize. So let me take this opportunity to introduce our next speaker. Our next speaker is Alan Morgan. Mr. Morgan serves as the Chief Executive Officer for the National Rural Health Association. As a leading national expert in rural health, Mr. Morgan has published extensively in the area. He's well known nationally for his work in rural oral health. His talk today is titled Rural Oral Health Care Access, a Policy Perspective. Please join me in welcoming Mr. Alan Morgan.
Good morning, can you hear me? Good, good. So I know you're thinking, how are we going to transition from world healthcare to rural healthcare? Oh, I have a story for that. Okay, so 10 years ago, I was contacted, seriously, this is not a joke, this is an actual story that happened. I was contacted by the United States Department of Defense to join a team that was traveling to the jungles of Peru to assess and evaluate healthcare in rural Peru and report back with recommendations to the Peruvian Ministry of Health. Yeah, that really happened. It seemed like a good idea at the time, so I did it. What an amazing opportunity for a kid from small town Kansas to be doing his Walter Mitty fantasy of traveling through rural and remote Peru and making that report back. So the obvious question you should be asking is, what the heck does the United States Department of Defense care about rural health care in Peru? In Peru! Okay, so a decade ago, they were having a presidential election, and in a neighboring country, there's a guy by the name of Hugo Chavez. Maybe some of you know of him. And he had decided to actually meddle in the Peruvian presidential elections. And so the Department of Defense realized at that time that poor access, should say this, he was meddling and he had identified an authoritative strongman who was running for president of Peru. So the Department of Defense had determined at that time that poor health care in rural Peru might actually result in the election of a military authoritarian strongman as president of Peru, which of course could never happen in the United States. But the point being on this, and what I'm trying to drive home is, rural health care really does matter. It has an impact on elections, and especially looking at health care today, this drives policy, drives elections, and you get results as a result of that. Fantastic timing today because the Journal of American Medical Association just released a report, and for those of you that do follow me on Twitter, my morning rant was on this report, which states that 1 in 3 rural Americans today report problems with paying for medical bills. And they actually highlight the issue of oral health care in this journal article. So such an important and timely research coming out the very day I'm talking on that. Isn't that fantastic? It says, if I control the space-time continuum for health policy, release the report now. You can probably tell this is not your normal presentation, right? It's a little different for those of you who have not heard me speak in the past. But the fact of the matter is, let's be honest, people don't care about rural health. They don't. I have 45 minutes today to convince you that rural health matters. So I'm going to try to do that in a lively, sometimes comedic way, just to drive home the point of how very important this discussion on rural health is. Now, I've actually put together a thoughtful approach to this, and let me, at the beginning, lay out how this is going to roll out. I'm going to, during the very first part, 5 to 10 minutes, talk with you about rural oral health in specific. And I'm going to specifically give you tools and resources you can take back home. When you come to a presentation, you like to be able to leave with resources. So that is the give to make sure that this is a good use of your time. Then I'm going to spend about 15 to 20 minutes talking about rural America. And I'm going to dispel a lot of myths and really hopefully give you an authentic feel for what's happening out there right now. And then the final 10 minutes, I'm going to actually wrap up of where we go from here, which actually is probably the most important thing that I talk about. What actually is happening in rural America, so that way you know, how can I engage? How do I fit into this? Is this relevant to what I'm seeing? So hopefully those three things all flow together nicely. So let's start with this. 5 years ago, the National Rural Health Association joined and collaborated with others in the oral health field to create a rural oral health initiative. And I'm not going to read the slides are all up there for you to read, but we focus in on policy, education, research, and communication, the four major topics of this. Why? Because policy and research informs policy, policy drives practice. If you start with the research component of it, you can change health policy going forward. You have to have that research component on it. So very, very important. So tool number one, if you do not listen to anything else I say today, just write down rural health. That's all you need, rural health. Google, Yahoo, Bing, any search engine, type in the words rural health. Our association is always the first thing that pops up. We're not a paid search engine site. It's just that we have the resources for research, education, best practices, so normally that happens. On our website, you're going to want to find programs, and under programs, you'll find our Rural Oral Health Initiative. And this is one-stop shopping for all the research, best practices, innovative approaches, what's working out there in rural health policy. If you're on your cell phone, you should see a view that looks something along this. So very important. Right now, we are in the process of collecting best practices for rural oral health. You can click on the link and submit your submission that will be evaluated by our advisory panel to determine this actually is a successful, evidence-based approach to delivering oral health care on there. I mentioned we actually have an advisory committee made up of 25 of the nation's leading experts on rural oral health that help guide us. We've developed policy. As an organization, as any organizations that are nonprofit, nonpartisan, what we do is we follow the research, we identify best practices, and then what's really important, and especially to the group here today, is we identify obstacles, barriers for replicating those best practices. That's where you see the policy. What legislative and regulatory changes need to be made in order for these success stories to be replicated across the United States? So that's what we focus in on that. You can't go it alone. And what we've done also is harness and collaborate the abilities of other national organizations, such as Families USA, to help spread these best practices and policy changes that need to occur when it comes to rural health. I mentioned the fact that we have developed an interest group within our membership. Maybe it's a good opportunity just to back up a little bit. I mentioned we're a nonprofit, nonpartisan organization. We are a painfully diverse organization. And by that I mean on my board of trustees, I have a rural hospital CEO seated next to a state employee that oversees state initiatives in rural, seated next to a rural researcher, seated next to a rural nurse, seated next to, well, you get the idea. These are a lot of people that the only common thing is they care about rural. They don't even like each other. But the important thing is, because of this eclectic mix coming together, they're able to develop good policy that works. And as that, then within our membership, and they identify by different categories, we allow them to come together on key issues, oral health being among them. Something that's new for our organization, and another great takeaway, is this really is the first time that our association has gone beyond research and education and collaboration into actually improving rural health. We have taken the opportunity to create a national rural community health workers program, and we're able to successfully create the first certified oral health curriculum for the state of Texas. These are real people. This is the graduating class of one of them. I love this because the approach of community health workers, of using trusted resources within your own community to be able to promote good, solid oral health practices within your community. Does that resonate for everyone? I want to make sure I'm connecting with everyone. As a side story that's not even remotely appropriate to share, but I had my teeth cleaning last week, and my dentist recognized and actually acknowledged, Alan, you are actually doing a good job. The way she said that made me wonder and worry more than actually affirmation, and she wanted to know what had prompted this good behavior. I said, well, I'm going to be honest with you. We really have engaged a lot more on oral health. I'm speaking at a lot more oral health conferences, and I feel really self-conscious in front of all these oral health people, and so I'm actually flossing. So neither here nor there. I've gotten way off topic. Let's get back on topic. Am I talking fast enough for everyone? Good. I got a lot of stuff to cover. Research. The National Rural Health Association publishes the Journal of Rural Health. If you are in the field of research, this is where you want to be. This is the room where it happens. I know that Australia would complain and say that their journal is really a good journal, and it is, but it's not the Journal of Rural Health. We are the world's preeminent research authority on that. And we were able to include a special section on oral health dedicated towards what does the research tell us about this? And we will continue doing this in the future. You actually have to support research, to get research to make sure that drives the practice and policy that you want going ahead. Okay, research, policy, best practices, tools, you have them. Who's ready to talk about rural America? Okay, good, good. I love this picture. Isn't it glorious? It's the father with his daughter. They're looking out in the sunset. Oh, Shangri-La, right? And they're out in the sunset. They see workforce shortages, vulnerable populations, chronic poverty. Such is the dichotomy of rural America today. The truth lies in between. It's so very tough because from a media standpoint, they either want to share the story of rural America as a Shangri-La, or you end up hearing that rural America is a horrific hellhole we're all trying to escape from. It is neither. It is actually, there is a sweet spot in between where we do have challenges, but amazing innovation is happening in a rural context. From a news perspective, from a policy perspective, it's not surprising that we focus so much on the concept of declining life expectancies. Declining life expectancies in rural. From 1991 until today, rural life expectancy has continued to decrease. It's gotten so bad that we're now dragging down overall life expectancy, and you may have caught from the news the last 2 to 3 years, the national life expectancy in all of the United States is declining. We're leading that, so let's talk about that. First of all, chronic health conditions. Look at the shape of this map. I'm not going to detail the map. This just indicates chronic health. You got the image of this map in your mind? Okay, let's look at this map. This is NRHA membership. See something? Yes, yes, yes. You can spend an entire conference, you can spend multiple hours on the discussion of what is the definition of rural America? or you can just look at health disparities and be able to clearly identify where rural America is. We have more than 22,000 members, all 50 states. You can see the distribution out there. You note that where you would expect a lot of rural Americans, you don't see a lot of rural Americans. Why is that? Well, okay, you've got to be with me on this. That's because that is all federally owned land, almost. Actually, it's about a two-thirds, maybe one-third of it is federally owned land. The other two-thirds is owned by Ted Turner. You got to stay awake during this presentation. Okay. Rural is not a small version of urban. It is a unique healthcare delivery environment. It is that place where those most in need of healthcare services have the fewest options available to access that care. That makes it different. You'll also see that it is an older, sicker, and poorer population. It is a poorer population. Income drives health status. So much of that we've already heard about throughout this conversation today. I like this chart because this chart actually gives the full breadth of what we're looking at right now. And I would just call your attention to 3 points on this. Number one, premature death. Yeah, that's accurate. Hard to believe, right? That is actually accurate. There is almost a 62% difference between life expectancy, rural versus urban. Just let that sink in for a little bit. Other one I'd highlight is what we're talking about, dental provider access, 30 to 65% in urban. Right to the point. Now here's one that I'm going to go ahead and highlight just as an interesting aside, veterans care. All right, you don't have to say it out loud, but in your head, who cares for the nation's rural veterans? Think about it. I know who you're thinking. The VA, right? Yeah, okay, so this is we're among friends and family here. Some of these are not going to go over as well because you already know the data. For those few people in here that don't know that, the VA actually only handles roughly 30% of the health care for rural Americans. Roughly 50%, I believe, or 45%. The veterans are not eligible because it's not service-related. There is a chunk that just can't travel far enough to the VA or to CBOX to seek care. And then there's also a percentage that just don't know they're eligible. So at the end of the day, as an organization, as many organizations, we focus in on the VA. The VA is important, but from a rural context, you're talking about 70% of the population that is needing to access their health care outside of the VA. So just a health policy aside as we're moving ahead. All right. Deaths of despair. That sounds like a novel, doesn't it? Deaths of despair. That was coined by the Washington Post. I've always hated that. I don't think it's accurate. I'm so happy for those of you who follows equity issues on Twitter. Show of hands. Audience participation, you okay? Sorry about that. I'll try not to do that anymore. But for those of you that follow equity issues on Twitter, you see there's thankfully a huge discussion on the titles Death of Despair, which, believe it or not, ties right back to our amazing presentation yesterday morning on racism. It's amazing to me how racism, institutional, direct, indirect, impacts almost every aspect of health policy in a rural context. And people don't even realize it. And really, this concept of the rural opioid crisis, ladies and gentlemen, rural America has had a substance abuse problem, a crisis for decades. This is not new, but all of a sudden, whoa, we got opioids, this is huge, we got to do something about it. Why? Well, as I began to, 2 years ago, begin to talk about the opioid crisis out in rural populations, most of the audience sat there with their arms crossed, and I could just tell in their facial expressions. You can read audiences. They were not connecting. And they were not connecting because The opioid crisis had come and it had gone. And now they were dealing with a crisis of meth, a crisis of other drugs. Why? Because opioids kill you. Opioids kill you. Meth is incredibly cheap right now. It doesn't kill you, and it's easy to obtain in a rural context. But we're all focusing on the opioid crisis because, well, that's the PTA chair, and that's little Billy Buffman, who's the quarterback of the high school football team. We don't want to talk about populations that are dealing with crack, meth, marijuana, whatever you have. We don't want to discuss those. And it's interesting going ahead, and I will note this, is how you hear this discussed. I'll be honest and I'll be out front. We're going to continue to talk about the opioid crisis because it has support. We need the funding and the support out in rural America. But once you start moving beyond opioids, people realize that they really don't want to spend a lot of money on those populations. This is a theme throughout rural. And so the discussion is moving away from, at an equity standpoint, of are these really deaths of despair, or is this a problem with the concept of whiteness? And for those of you that have read the publications on this, I won't go into detail for this, but again, I will say it goes right back to the very timely conversation we had yesterday on the issue of racism. You didn't expect this presentation to veer off here, did you? But this is exactly relative to what we're talking about. All right. Now, let's get on to some really happy news. Rural hospitals are closing. We have a rural hospital closure crisis. 120 rural hospitals have closed since 2010. Now, for those of you that really do like health policy because it's cool, this really is some good stuff to get into because I think it tells a story. I think it tells a more layered story than just rural hospitals are closing. What do we do about that? So bear with me on this. This shows you closures by year. And you can see we're actually into a second wave of rural hospital closures. We're into a second wave of rural hospital closures. And what happens this year for closures either makes for an incredibly sad story or rural hospitals are closing either way. Let me walk you through what I'm thinking. And then, again, in your own, am I right? Am I wrong? How close am I to this? Because it has an issue to do with everything we've talked about so far. This is a map of the United States, believe it or not, depicted by squares, which makes it a little difficult to follow. But what I want to share with you on the next 3 slides is where we've been, where we're at, and where we're headed with rural hospital closures because I think it tells a deeper story. Where we've been, these are hospitals that have closed. What do you see? Southeast United States. According to SHEP's Center for Rural Health, University of North Carolina, the closures in the past have predominantly happened in rural communities with high African American populations. These are the communities that have lost access to health care for their hospital. Okay, where are we at right now? Well, to look at where we're at right now, you look at what are hospitals currently seeing from a profit margin standpoint. And I know this sounds crazy, but 48% of the nation's rural hospitals currently have a negative profit margin. Half of the rural hospitals currently have a negative profit margin. How do you operate like that? Okay, so that tells us where we're at right now. Where are we going? To look at where we're going, we partnered with an analytical firm, iVantage Analytical, to look at inpatient, outpatient, community demographics to paint a picture of these vulnerable hospitals. You have to take an indirect approach to figuring out whether a hospital is at risk for closure. And what do we see? What do we see? Okay, I'm going to go back, and I'm going to drag you through this. What is closed? Southeast U.S. Where we're at right now, we're starting to move into upper Midwest. Where are we headed? Wow, upper Midwest, upper Northeast, out West. That's crazy. That's crazy. So all of a sudden, we have national attention on this rural hospital closure issue. All right, stick with me, stick with me. let me go back to this. The first wave, as indicated by University of North Carolina, high Medicaid populations, states that it did not expand Medicaid, communities with predominantly African American populations. This second wave, believe it or not, upper Midwest, predominantly white populations. Y'all with me on this? Can I get an amen? Amen. All right. Well, what I'm trying to do is I'm trying to help out the organizers for telling them they did such a thoughtful job of constructing this program because all the presentations fall together, right? They make sense. Okay, all right, that is enough. All right, that is enough, that is enough, that is enough. I think I've articulately through research demonstrated that the wheels are falling off the cart, right? So let's just back up a little bit and let's talk about what's working in rural America right now. And let me start by saying this. If you care about policy, rural health is where all innovation occurs. Innovation is forced to happen in a rural context because of workforce shortages, declining populations in certain rural communities. There's a forced innovation that's happening. In fact, I would argue, and this is the right audience to disagree with me, name me an innovation in health policy that began in an urban context. Name me an innovation in healthcare that began in an urban context. Well, certainly not telehealth. I mean, with the exception of NASA, I mean, we own telehealth. And I would argue that Mars is pretty rural, so put that over there. Community health workers, our organization back in the early 80s was the first to develop a policy paper on what a community health worker is. It is a rural concept. Patient navigators, Hazard, Kentucky, we own that too. Dental health aides, oh, what about Alaska? Again and again and again, if you really want to see where the country is going from health policy, whether it's oral health to behavioral health to primary care, you need to find out what's happening in a rural context. And that is the reason why rural matters. I hear so often, people are dying, they're getting old, they're moving away. What are you going to do? That is what I hear in DC. What are you going to do? First of all, innovation is occurring, so you want to foster that. Two, they are not dying. Rural America is not dying. Look at the data. For the last 5 years, according to the US Census, rural populations are increasing. Rural communities adjacent to urban are the fastest growing. Urban hub populations are actually decreasing. A wonderful professor by the name of Sarah Smarsh, who published an amazing book, Heartland. Show of hands, one more audience participation. Who's read Sarah's book? Oh, good, there's another takeaway. Read the book. Go on Amazon.com. She is actually going to be our keynote speaker. She is leading the rural health, rural America renaissance. She talks about growing up in poverty in a small town in Kansas and the challenges that people face in trying to break the cycle of poverty. But she also does an amazing job of talking about the assets in rural America. And in a New York Times article published last fall, she highlights the fact that rural populations are growing. We have a renaissance. Some of the best and amazing examples of healthcare quality can be found in a rural standpoint. In fact, we do that yearly as an organization. We highlight the top 100 rural community hospitals and the top 20 critical access hospitals. These are hospitals with 25 or fewer beds. And it's always jarring to people that haven't followed that. Sure, when you look at invasive healthcare procedures, you're going to look at quality in a large urban context. But for primary care, almost always you see the healthcare quality indicators among these rural clinicians being higher than their urban counterparts. If you need primary care, you really need to look towards rural America. You really need to look towards rural America for that. And it makes sense, right? Whether you're in oral health care or behavioral health or primary, any type of family medicine, not only do you know your patient, you know that they had the 2 cheese dogs at the ball game last night because you sat beside them. They're in your community. They allow that context of knowing more about the patient and prevent a lot of the patient handoff errors that we see in a larger context from other institutions. This is not just the case of a bunch of baby boomers moving back to rural America to relive their glory days. We actually see the youth population in rural America expanding. This has a direct impact and relation on the need to ensure access to oral health care. This has a direct need on that access. All right, so this is not a promotion of NRHA. This is here just to remind me now to slide onto the issue of innovation in a rural context as we're going ahead. I mentioned that briefly, so let's talk about that. Currently, we have just completed year 1 of the Rural Global Budget Demonstration in the state of Pennsylvania. 4 rural hospitals are now in year 2, and they've added, I believe, 8 to 10 more hospitals into this demo cohort, taking a look at a global budget payment model for rural hospitals. What does that matter for oral health? Everything. Because this is actually the payment transformation to a public health perspective that we have long fought for the last 30 years. What this does, I don't know how this would work in an urban context. Don't ask me how it would work in an urban context. I only care about rural. But what it does is it takes a look among all payers, private, Medicare, Medicaid. What was the total expenditures for a particular rural community for the last 3 years? Averages those, includes a bump up for cost of living every year after that, writes the check. Here you go. Every month, this rural hospital is getting X amount of payment. Have fun with it. You do have to create a transformation plan, which tells how you're going to do population health to actually keep your community healthy. But you already get the concept of this. This is forcing rural hospital CEOs not to worry about how many people are in their emergency room. It's how many people have they kept out of their emergency room. How have they connected and coordinated with oral health, with community health, to keep the patients healthy in the first place. It completely transforms the trajectory of how we do. This is cool stuff. This is what we've always tried. This is what, okay, we've been through iterations of this. I get this in the past. Accountable care organizations, other payment models. But this is the end game of where we're going. I am sure there's going to be glitches in this going ahead. I am sure there's going to be problems on this. But from the initial results of this and hearing from the hospital CEOs directly, said, I love being a connector. I love now trying to keep my community healthy. This is why I got into the business, not trying to get people into my emergency room. How do I actually obtain higher healthcare status among my populations? That is fantastic stuff. And you can see for this type of payment actually provides federal and private sector payment to pay for preventative service and oral health care. I mean, this is how we get the funding to make what we want happen. And this is happening from a rural context. Again, I have no idea how this happens in an urban context. I really don't even care. I'm not paid to care, and I don't personally care. But as usually happens with these innovations, urban people usually get around to figuring it out. So I'm sure they will. That is from the payment component. Now, as I mentioned, also you've got how do we change the delivery in totality on this going ahead? And that's where you get into the rapid expansion of community health workers and trusted resources in the community of getting out there, sharing information, and making sure that patients are seeing their primary care physicians, seeing their dentists, seeing their dental hygienist of when they're most needed on this. There's also a new change being discussed right now of what actually is a hospital, because currently in the United States, a hospital by necessity has to have inpatient beds. legislation on both the House and the Senate, and proposals being talked about within the administration to provide a new rural hospital type that doesn't have inpatient beds, one that has outpatient, high reliance on telehealth, a real community needs assessment being done, not just having the summer intern do our community needs assessment, but actually meeting with the community. What are the needs of your particular community going ahead? So I hope what I'm painting is a real renaissance happening, not just in what rural is, but how we deliver health care from a rural context. This is really exciting stuff, and I haven't even gotten to teledentistry and the role that telehealth plays in all of this. This year, we're going to see an amazing expansion. How's that for a bold prediction? This year, we're going to see an amazing expansion of adoption and utilization of telehealth in a rural context. The only significant barrier to this moving ahead is broadband access in a rural component. If you travel in the upper Midwest, you travel in Appalachia, you realize we're still trying to figure out cell phone coverage. We haven't even gotten to high-speed internet. So that's why you're not going to see any major changes forward. But it's intriguing to see how this already has been employed in rural communities. And one thing I want to conclude here with is I think a lot of times when you think about, okay, oral health care or primary care in a rural context, you think of, okay, we know that there's problems. How do we at least try to get some bottom line healthcare coverage out there? And many times it's exactly the opposite of that. Two great examples, not related to oral health, but I do want to share them. In the state of Tennessee, up in the upper Appalachia component of it, they've got a great telehealth program for cancer screening. And so we're able to see that and expand access to cancer screening among populations that just wouldn't have that. And it was interesting to hear the clinicians say of how much more accurate and more precise her diagnosis for cancer, skin cancer, were using telehealth than in person because of the high definition and to be able to zoom in. She says, I can perform better health care remotely. I mean, just think about that for a second. I also think another example in South Dakota at a NICU unit, of all the things you would think about, and maternal child health is such a huge problem in rural America. But in this particular case, a specialist with 4 RNs and a couple MPs on site was able, through Bluetooth technology and her stethoscope, to actually assess better for the infants, and then she would be able to, they're local. She says, I'm able to, on my computer, erase out all the ambient noise. I really get an accurate reading. This is much better for where I'm at to be doing this. So what I'm trying to say to you as we leave this, and again, I know we've cycled from global health down to rural, is, and this is the end of the conference almost, please don't think of rural as an afterthought of where we're going. In particular for this, if you want to know what's new, what's exciting, what's going to happen in rural oral health, you really need to look towards rural first, because that's where we're first going to see it in practice. So again, for the 4 people in the room that are on Twitter, that's my Twitter handle, if that's what we call that. And I would be happy at this time to report that I have stayed absolutely on schedule. How did that happen? And happy to take any questions at this time. Thank you. Yes, but I can't hear you, so I can't answer.
Can you hear me? Okay.
Yes.
Great. So, great things are happening in rural health, it sounds like. And I'm wondering if you can tell us about any successful workforce development strategies that you've heard about in rural health settings. Are we all into the telehealth adoption? Are we beefing up allied health staff? What's that looking like?
Oh, fantastic. Well, we all know how we educate healthcare professionals in the United States, right? We take the brightest and the best from upper income urban areas, we train them in urban areas, and then we're dumbfounded that they don't want to practice in rural America. Weird, right? How do you move from there? There you go. There's your statement. What we're seeing right now over the last 5 years, let me talk about, is a realization nationally, and it was mentioned by actually a couple of the other speakers. We need to grow our own. We need to make sure that people within the community know that they can stay in the community, that there is a future for them through the healthcare profession, whether that be oral health or primary care or anything on that. As an institution, we need to be doing progressive means to make this happen. Now, Health Affairs that just came out 2 months ago indicates, oh my word, what is it? It's ridiculous. Something like only 10% or fewer of the nation's medical students are from a rural area. So we haven't even crossed that. But even when we get to that, we have medical professionals here in the audience with us. And when I talk with them, regardless of what other their educational background, they all have the painful same story, that they all share they're in the school, and at some point a trusted teacher told them, "You're too smart. Why are you going into rural health? You're too smart. Why are you going into rural health?" I mean, even if you get the right kid, you have to make sure that they're in rural residency training programs. You have to surround them with peers that are able to support them to make sure that they know this is an option for them. This matters. This matters. This is an option. And I don't buy into another saying is, well, you understand, rural populations, no one wants to live in rural because you don't have all the great shopping and everything. We have the internet now, people, even if it's not fast, we have the internet. And I go back to the same thing. That's a cop-out to allow people to continue to promote upper income urban people into the medical profession pipeline. We've got to be able to have people that represent our own communities going into the healthcare profession. So directly to your answer, rural residency training programs, making sure that pipeline programs that grow and promote, scholarships, loan forgiveness, tremendous success for that, certainly on the state level, but also on the federal level. HRSA, National Service Corps, which was mentioned earlier, I have to do a huge shout out for that. For those of you that do, I hope, I need a day. I don't have a day. But within the next couple months, for those of you that follow National Health Service Corps, they're actually going to release a mapping tool, which we all can use online, which shows placements of National Health Service Corps people over the last, 50 years? I forget. Or longer. So finally, people like me are going to be able to see, oh, you say you love rural, do you love rural? And I'm going to be able to see how the placements have gone on this. So I think that also will be a tremendous tool once you know the actual data to see, okay, this is working, this is not working. How do we change this to make sure we have adequate providers? Finally, you mentioned telehealth is a great tool. It is not a solution. All right. Next question. Yes.
Well, I am one of those people that I would like to make rural. I'm usually pretty loud.
You are?
I am pretty loud. I have always loved living in rural areas. I lived in an area of northern Nevada for a number of years. But one of the challenges I can say, I'd love to live further out than where I do currently in Texas, and most of the people would consider sort of rural. But the challenge is when you have a family and you have a spouse, one of the challenges, and I heard this from practitioners in Nevada as well, is that it's not just about you practicing, it's your spouse being able to be employed in that rural area as well. So, we need to think on a broader perspective, I think, about if we want to recruit people to go into those rural areas, that is there a way for us to assist that family in transitioning? Because it's not just about one person typically.
Oh my gosh, that's perfect. There's a gentleman by the name of Dr. David Schmitz who heads family medicine in the University of North Dakota. He's developed what he calls a rural APGAR. For those of you that are clinicians immediately know what I'm talking about on that. And he's able to go into the community, do a quick assessment of the community and determine how they better recruit and retain professionals. And Dave's the first one to say that spousal component is not recognized as such a huge factor. And it's not just how do you get the spouse in? There's also that concern of people moving into rural communities are concerned they don't want to move there because how are they going to find a spouse, for those of you that are interested in that. So it is a huge issue. I just simply go back to the same thing. I mentioned, I think you saw from my bio, 30 years in health policy, 20 years in the National Rural Health Association, all of which trapped in our nation's capital, which is a wonderful place to visit, terrible place to live. Originally from Holton, Kansas. I cannot wait to get back to Holton, Kansas. I cannot wait to get back. If you're from a rural community, you want that. You want that. You value it. You recognize the benefits. And that switch of approach, of a focus on rural populations and making sure that we get it, that's the only successful strategy going ahead. But your point is well taken. Well taken. Thank you for, do I have anyone else in here from a rural community? Yes, my people. Thank you. Any other questions?
I had one, Alan. Thanks for, I'm over here.
I'm lost.
Right.
There we go. I see you now.
Yep. Yeah, thanks for a fabulous talk. I live in an urban area, but most of my research work is actually in the rural area because I'm into teledentistry and some of the stuff that we are doing obviously reflects very much what you have been saying. But what I actually wanted to ask you about goes back to some of the stuff that you're talking about, getting hold of talented young people to get into dental school. We did an analysis of our graduates a couple of years ago, and which showed that if you came from a rural area as a dental graduate, you were 7 times more probable to go back to a rural area than somebody who came from an urban area. Unfortunately, the paper was not good enough for the Journal of Rural Health, but yeah, I'm sorry. Yeah. But
calling me out. Oh.
Anyway,
right. Well,
what I really want, so it led me to make a very serious point to the admissions office. I mean, that what do we actually do to recruit more people from rural areas? Because it clearly would help us to get better coverage out in those areas. In Oregon, we have a lot of rural areas without dental professionals. And the dental school is much too late. I mean, it's much too late even for college. I mean, so my question probably is, how do you get involved, you as an association, how do you get involved in strengthening the education system in the rural areas? Because I believe that it probably is around late middle school, high school, where you actually need to make the push in order to be able to get those candidates to apply to dental school later.
Oh, it's such a good question. I think it's a good question because it's, you're asking me, but this is directly relative to everyone in the audience. We work very hard, we all should work very hard, of getting out of our sector. And so, particularly to that, I recognize that I can talk all I want about among my hospital members, my primary care, my oral health, and I'm preaching to the choir. But in that regard, the only way we're going to move the needle is me connecting with the National Association of High School Educators and meeting with the National Rural Education Association, meeting with Farm Bureau, Farmers Union, National Rural Electric Cooperative, National Rural Broadband Association. It's amazing to me how much of my work as CEO, my staff is really focused in on particularly only health policies, but so much of mine is outside my sector because unless you get the educators on board and their trade associations, you can't move. And the same thing at a local level, getting outside of your healthcare peers to talking across sector within the community. Because education, schools, small business, the 3 pillars of keeping a rural community alive, you can't have that. And what I didn't touch on as much, two points, what I didn't touch on as much is when a rural hospital closes, let's be honest, no one really cares because a lot of them are 40-year-old institutions. I really don't even care if a rural hospital closes. What I care is that you lose that 24/7 emergency room service because if you're an elderly person, you should not live within 30 miles of a 24/7 emergency room. What I care is you don't have maternal health care. As a young family, you should not be living in a rural community. So access to maternal care, access to emergency room, that keeps the rural communities intact. But then on the issue of oral health, and let me try to steal some thunder of a great idea I'd heard earlier today and already try it out, but that concept of employment without a good set of teeth and what that means from a rural context, and moving the country forward. So to your point, what NRHA is doing, getting outside the sector, a strong plea, talk to people you don't normally talk with. Collaborate. That's what makes rural great, right?
Alan, I have a question.
Yes.
Sorry. Oh, I have a bit of pulpit privilege. I thought I would ask. So I grew up in a rural community. It's no longer rural, but then I went to school in a rural community in Mississippi. So I went to Mississippi State University. It's really micropolitan. Then directly outside of that, it's all rural. My whole family grew up rural. And I remember the first scientific conference that I ever presented at. I was asked by an attendee if I wore shoes because I was from Mississippi. And it was really confusing because I was like, I'm literally wearing them right now. But I think to me it was a bit shocking because I didn't know that I was this kind of hillbilly country bumpkin, and I think it speaks to a culture that's pervasive, nationally, that rural people are just stupid or we're all under-resourced. And so my question is, how do we as advocates and health promoters and then just generally as people, how do we sort of work against that culture? How can we help educate? Like what are we doing wrong and what are we doing right in terms of shifting that culture?
Oh my goodness, thank you. Please promise me that on your way home, you're going to go on Amazon, spend $10 and get Sarah Smarsh's book. That's particularly what she talks about. And especially with your background, for those of you in the room, I didn't recognize how common everyone's experiences are from a rural perspective. And she talks about stories of the first generation going to college, which I was, and dealing with the misconceptions of their peers and how they treat you. And it's kind of funny, I kind of suppressed all that until I read Sarah's book. I'm like, wow, that actually happened. And it's always fun to find solidarity in that. But to your point, it's a communication issue of how we tell authentic stories about who we are from a rural community. How we tell authentic stories of who we are in a rural community. And that's so very important to be able to change the whole dialogue to currently what we have. Rural America is very diverse. It's becoming more diverse by the day. The demographics are shifting so rapidly. And one point to your point, another thing, rural is a study in place-based policy. Rural is a study in place-based policy. And we're the only group that as we succeed, we're no longer rural. And the really quirky thing, and I wouldn't say this on Capitol Hill, but among friends and family, I will say it. If you take rural 1950 to rural 2020 using the same definitions, it's a different story. Because as rural succeeds, which it does, population grows, it drops off. And so rural continues to shrink into the populations, and you get much higher health disparities, and the story becomes much more drastic than if we would use the same definitions that we had, even when we were backing kids as well too. So, wow, I hope I've enjoyed this. I don't know about you, but this has been very selfish good for me. Any other questions? Yes.
Yes, thank you so much. This is excellent information for us. The other thing, the cross-sectoral approaches to workforce, I would encourage people back home to also look at other apprenticeship programs. There was a federal Department of Labor grant. Some states used it for healthcare diversity, and our state in Colorado using it for apprenticeships in community colleges, we're focusing in public health to get them to focus on rural area recruitment into apprenticeships of certificate programs into community colleges, and also give jobs in healthcare settings so that they have a resume, an income, and then a future education opportunity. So there's some apprenticeships in general. There's a lot of work going on nationally around that. I wrote down a lot of what you suggested too, the other sectors. We've also talked a lot about intersectionality, of course, too. And, when there was initially in the U.S. the urban flight, like you're saying, the change of definition, now we have, the urban gentrification in many of our states, right? And so the intersectionality of rural populations that now have, in some of our states, much more likely to have, English as, not even a second language, maybe, primary language, non-English. Very low income, pushed out of jobs in community networks because of the high cost of living in the cities and the gentrification and lack of policies, social policies that keep people in their communities that they've been for generations, including the housing crisis and predatory housing practices too. So I don't know if there's any. There's answers are somewhere in the room altogether, right? But really, I don't know if you can address any of the intersectionality across rural populations, and especially given the demographic shifts we've seen in some states recently, and who might be some shining stars that are doing well with that or addressing.
Yeah,
those
good
community
point.
problems.
And thank you for bringing up housing. Because I always say if I'm in a room talking about rural health and we're not talking about housing and transportation, I'm in the wrong room. But it makes it more challenging because I know health, I don't know transportation, I don't know housing. We work very closely with the Housing Assistance Council on that. And the housing component, for me, I'm going to two examples. Number one, probably most importantly, it falls into substance abuse recovery issues from a health policy standpoint, and proper housing in a rural context. They just don't have the resources you have in the urban settings, and making sure that once a patient enters into the program for rehabilitation, they do not go right back to the community that helped lend itself for that. And really on that component, the only success that I've seen is direct collaboration with the United States Department of Agriculture in their loan program to be able to try to create housing as appropriate for that. So that's good. Transportation is the other component, I would say, cross-sector on dealing with that. There is a real push and a real move now for innovative approaches. Believe it or not, don't laugh. Uber and Lyft, and their focus for both of those, I think no one laughed. This is the first time no one laughed when I said that, good. Their focus in a rural context because, there's a lot of challenges for it, but from a rural standpoint, rural low income standpoint, trying to get to treatment, trying to get to your clinic, the options are just, unless you have family, non-existent. So a good example of successful issues, the way to deal with that. Good. There are so many. And again, one final plug, please, if you get the chance on the flight home, pull up our compendium of best practices for oral health published in 2017. And if you know anyone that's got good stories, click on the link that says submit your current 2020 for consideration. Identify best practices, replicate best practices. That's what we're all about.
I think we have one more question, and then we'll wrap up the session. Scott, who hasn't talked at all this conference, I thought maybe you'd want to give one last comment.
Two things really stuck out. I mean, the rural health disparities are obvious, and innovations start in rural health. So I guess my question is, are the innovations working?
Are the innovations working? Are the innovations working? Oh, heck yes. Are you kidding? And again, I get to the point of, this is why we all get it. Let's back up. I know right now we're paying for the light bill and we're sending our kids to swim lessons, but we all get into this because we want to make things better, that we want to improve things. And the fact that right now, using the hospital closure crisis and declining life expectancies as that driver to create a sustainable health system for the future, which we just haven't done. Finally, over the last 3 years, we've moved away from talking about how do we plug the dike with these Medicare, Medicaid solutions and these little things to how do we transform our healthcare system to one that keeps people healthy. And so for everyone here, you have to be excited about that and the role that oral health care will play into that. And again, just the initial results. Now, the state of Maryland has had a global budgeting proposal for the last 7 years, but it's kind of a modified one. This approach in Pennsylvania is so very important. Let me use that to say, if you followed the news just last week, Kansas expanded Medicaid. And Kansas, in that expansion, Medicaid actually has a provision directly to these, directing a commission to look at these innovative payment models, which is the global budgeting. So it's just going to rapidly expand to other states in the United States. So I'm optimistic. There are successful models that are happening, and I think we're on the right track. Go rural.
Thank you so much.